Hi everyone, my name is Paul Harasymowycz. I'm from University of Montreal.
I'm Ticiana De Francesco from Brazil.
And we're very happy to present to you the iTrack Advance, some cases that we picked together that we thought could be very educational for everyone thinking of using iTrack Advance or already using it. So, well, this is the case that I picked. So a young boy, his name is Alex, 17 years old, kind of reminded me of my children as well, goes to similar schools. He's really into sports, so he plays hockey, he plays football. Unfortunately, he also had juvenile rheumatoid arthritis, developed uveitis, uveitic type glaucoma, and when he was first referred to us, his pressures were super high. They were 35 and 43 on drops. And you see someone reminding you of your own children, you're like, oh my God, what am I going to choose to do this? He was actually a second referral, and often in these uveitic type cases, traditionally people would pick tubes. I don't know, is that similar in Brazil as well?
Yeah, it's still a little bit of a concept in Brazil.
So we know more and more that certain types of glaucoma respond well to iTrack or angle surgery in general. So I was thinking, I don't want to put a big piece of plastic right away in the 17-year-old.
Yeah.
I'd rather try to do something in the trabecular meshwork where most of the physiology, hopefully, is there. He was not on any steroid drops, however, so it's not a steroid response glaucoma. And there was no active inflammation. So those are important elements when choosing this type of angle surgery. You don't want to do it when you have active inflammation in the eye. You'll see his nerves were actually fine. His fields were full as well, but still having pressures in 45, he said, I really have to play hockey. I can't have surgery right away. We see the OCT, there's some pseudo progression here. We see that the nerve is thickened from the inflammation. So we didn't really think he's losing fibers very fast. However, we did have to put him on oral carbonic anhydrase inhibitors. And that also, having someone young, putting them on oral CAIs, it's not a great long-term solution. So we kind of agreed with him, with his family, that we'll probably proceed to perform iTrack Advance and combine it with a GAT or a hemi-GAT.
I'm just curious to ask you something. How is the situation of the angle influences you to go for example, for angle procedure like canaloplasty or GAT or versus tube? If the angle has synechia 360 degrees, do you go more for tubes, or do you even think considering doing goniosynechialysis and doing an angle procedure?
Yeah, that's a great question. Occasionally I'll do a little bit of goniosynechialysis, but if the angle is completely closed and it looks like a sick, red, inflamed eye, I probably would tend more towards tubes.
That's what I usually do as well,
Also, actually, interestingly that you mentioned, I had noted in his chart that his angle is very thin, the trabecular meshwork. So it wasn't like a very thick trabecular meshwork. So I thought again that if we can open that angle up, maybe he would have better outflow. And what's nice about the iTrack system is that it's 220 micron opening. So it can get into really thin or small canals, I find. So then we scheduled our patient. He had hemi-GAT with ABIC using the iTrack Advance. We really want the gonio-ready system. It's nice to have that extra hand-free when doing this surgery. We can go through the videos. Ticiana has amazing videos, so she'll maybe go through those more specifically, but basically this is his eye. We're going through and this is him a year out. We just saw him. His pressures now are 12 and 15. He's still using a few drops a day. He's playing hockey. He's playing football. He's graduating from high school. For me, this was a big win. We didn't do a surgery which can cause tube erosion. He's active. He still needs maybe a couple of drops. But I thought this was a win for him.
And maybe he will need a more aggressive surgery in the future. Who knows? But at least now, you're starting from the more simple procedure, more safe procedure, and then you go escalating, right? Yeah.
So I thought it was a nice case to illustrate the power of
super nice,
The other thing, we sometimes were imaging with anterior segment OCT, and I thought it was very nice to see that you can actually see the canal that's open as well as the collector channel. So more and more I think we'll be heading towards imaging using canaloplasty and those type of systems as well.
Beautiful. Do you find it harder to cannulate a Schlemm's canal of a patient with uveitic glaucoma?
I do.
You do?
It's a little more adhesive as well, as you had mentioned, but it's a case by case, and it's still worth the effort in trying in these cases.
And even if you're having a hard time to advance with the microcatheter or with like a suture, you can go back a little bit, maybe inject more viscoelastic, and then advance again, right?
Yeah, sometimes you break those adhesions.
Adhesions, yeah.
And sometimes we feel that trabecular meshwork herniates into Schlemm's canal.
Yeah.
So sometimes it's hard to, and then, like you said, you give a little microbolus, it opens it, or I'll just go in opposite, use the left hand, or create another wound to try to go from the other side. Yeah, that's a good pointer.
Nice. My case is not that like a complex case. I think it's more like a routine case that I'm going to show you soon. But and I'm gonna focus more in showing the surgical technique. I think we can discuss like step by step the surgical technique. And the interesting thing about the iTrack Advance is that you don't need to use a forceps to insert the microcatheter, right?
Yeah.
Okay, so this patient is a female patient, Caucasian, 70 years old. This patient had a strong family history of glaucoma. The father got blind from glaucoma. And this patient is going for cataract surgery. She has open angles, primary open angle glaucoma. Pressure in the right eye, that is the eye that we were going for surgery, was 25, and in the left eye 18. This patient was on 3 medications, and the vision was 20/40 already because of the cataract. As you can see, the OCT on the left eye is pretty good. The right eye, you can already observe some RNFL thinning, RNFL defect, and that correlates with the visual field defect. A nasal stab. Before deciding which surgery you want to go for, I think it's important to understand, okay, what is your target IOP? Right, for this patient, she had mild glaucoma. She was 70, so I would say, okay, her target IOP can be up to 18, and I don't think this patient needs a bleb surgery. She could go well with a combined phaco and Schlemm's canal procedure.
I noticed, so the initial incision is important as well. So I'm not sure, there's a debate sometimes when you're sitting clear cornea temporal. Do you make your incision just adjacent and attack the angle more straight ahead, or do you do more like a gut incision on the side, or in between?
In between, because the GAT, I think I do more like a close to the nasal angle.
Yep.
Like, and when I use for the iTrack, I do like around 2 clock hours from the main incision, the main phaco incision.
Okay.
Yeah. And you?
I kind of put it like yourself, a little closer than usual. The GAT will be further away. The other thing that you'll see when you're using the inserter is because it has a little bit of a sharp cannulated tip, sometimes it's hard to get in, or when the patient is looking away, you're kind of trying to see, how do I get that instrument in?
So sometimes it upside down, right?
Yeah, I do like a little ice cream scoop. So you kind of go, shoop, you go in, and then
you turn.
Sometimes also what we've started doing is marking the cornea kind of on the spot with a little marker, and that way we kind of know and we're not fishing around.
Yeah.
And I find that can kind of help you guide.
I think the place where you're going to put in your incision and the direction of your incision is going to make a difference here.
Yeah.
Otherwise, you're going to have a hard time getting into the Schlemm's canal, right?
Yeah.
Yeah.
So make sure that you make that incision towards the angle, scoop it in, and then what are your other pointers?
So this would be one tip. I think the second tip is when you're going into the Schlemm's canal with the tip of the injector, put the tip a little bit up, maybe like 50 degrees up.
Yep.
So you make sure you go inside the Schlemm's canal and you're not going to the suprachoroidal space or something.
The other thing, when you're making your paracentesis, pure cataract surgeons, you're often going through limbal vessels. That may create a little bit of hemorrhage, which will go on the surface of the eye and obscure your view. So just to go slightly more anterior than you usually do. For most angle surgeries, try to be a little more anterior, not right at the limbus, and create those little bleeding.
Yeah, it's interesting also because we know one of the advantages of the iTrack Advance is to inject more viscoelastic, right? To be able to viscodilate more. Depending on the patient, do you decide how much viscoelastic you're going to inject, or you inject the same for all the patients, and how many clicks do you do per hour? How do you usually do it?
Well, I try to get at least 40 to 60 clicks. So I try to divide the quadrant into 4, and as I'm retracting, it depends what music you're playing in the OR. If it's like too slow, then you need like something, you want them to be clicking, but so you end up telling whoever's assisting you, click, 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 click,
and
click.
It's very important to be synced
It is.
with the assistant, with your scrub nurse, because she's going to be the one rotating, right? She
Yeah.
needs to be also understanding what is happening. Yeah.
Exactly. And the reason we're saying that is if you stay in place and you're just clicking in the same place and you're not moving, then you can also get a decimate
Decimate attachment,
detachment.
yeah.
And that's why it's important to keep mobility, but not to go too fast. So that way you don't get the advantage of
Yeah.
viscodilating.
Yeah,
Yep.
yeah, agree, yeah.
What kind of viscoelastic do you choose? Or
So I usually use Helon,
Yeah.
Helon GV, yeah.
yeah, similar. There are different studies looking at Helon, Helon Pro, Helon GV. I think most of them,
Yeah.
as long as you get enough volume,
Yeah.
should be quite
Yeah.
good. Oh, so what we want to know what happened to your patient.
I brought the result later on, 6 months after the surgery. Before pressure was 25, now pressure is 18 on target. But she was good. She was stable. This case was actually a case that I did a long time ago. Was in Canada. Yeah, it was an interesting case. Yeah.
Nice. And do you tell your patients you'll get them off some of the drops, or they may need?
That's an interesting point, because for this patient, her pressure was high already. And so I said, you know what, the goal of your surgery is not to reduce your drops, it's to reduce your pressure. And if we can reduce the drops, that's a bonus.
True.
But the goal is to avoid a more invasive procedure. Yeah,
Yeah, I
that's
agree
what I
with
told
you.
her.
And sometimes if you combine it, let's say with a full GAT, then maybe you can get them off more medications.
Yeah.
But I agree with you, a pure ABIC can still give you a nice mid-teen range.
Yeah,
So
and for that case, I did pretty similar what you did. I did 360-degree canaloplasty and also did 180 hemi GAT.
Nice.
Yeah. So it was pretty good result.
it was great to join you
Great. Always
guys.
great to be
Hopefully
with
these
you.
tips will help you in your practice.
Yeah.
Yeah. Thank you.